So next presentation is by Dr. Unnikrishnan Nair. He'll be speaking on outer retinal microvascular changes in Mactal differentiating patterns.
So we'll be talking about Mactal. So it's a clinical diagnosis that we all know. Starting with graying of the retina, then we said pigmentary changes, and finally ending in scarring, which makes the diagnosis pretty obvious. And this is one of the dreaded complications where you find a development of a choroidal neovascular membrane picked up well on angiography, though the OCTA forms the bedrock of diagnosis in secondary CNVMs in Mactal. You get beautiful images of the vascular network in the layers. And this is what I want to show you. This is the progression of the layers in which you see in the avascular zone, which is supposed to be avascular by name, you see a network, contrasting to a non-proliferative Mactal where you don't see anything in the avascular zone. So this is the crux of the paper. Sometimes in the avascular zone, you see vasculature. And that vasculature is what we call OCT-based microvascular, outer retinal microvascular changes. And it is associated with this particular new OCT finding called aura, or outer retina associated hyperreflectivity. So what is aura? You see it with the study was 117 eyes, of which 35 eyes had aura. Both of them had equal OCT and OCTA findings. So this is what you mean by aura. It's a hyperreflectivity in contact with the RP. You see a hyperreflectivity in the outermost retinal layers in contact with the RP is called aura. And what happens, it may be due to pigment migration, and it may be due to vascularization. So that is what we're studying here. The OCT features studied were those related to Mactal, including hyperreflective foci, the formation of hyperreflectivity, pigment plaques, and eventually, this is something that was important. We studied the change of the contour, that is a retina going down. That's called subsidence. That is the vertical support of the retina is not there and it goes down to the outer retinal layers. But we also studied vascular features. That is the presence of a double layer sign, as you see here, and also the eventual features of a subretinal neovascular membrane. The OCT features studied were the presence of a right angle vessel vascular invasion, which I'll come to later, a retinochoroidal anastomosis, a vessel going throughout the length of retina, and eventually the formation of an SRNVM. So these were the findings. You can see that we studied the subsidence, the loss of the ellipsoid, the cystoids, and this is important. Whenever there was an increase in subsidence or easy loss, indicating the atrophic element, you could find there was vascular invasion. The plexuses would actually go down. So on the right-hand picture, you can see what a vascular invasion is. It is not a CNVM. On the left-hand picture, you see the OCT shows a CNVM. So the crux of the study, the vascular invasion was always associated with subsidence, the retina going down and the vasculature appearing in a level it is not supposed to be there. A retinochoroidal anastomosis was when the retinal changes happen throughout the layers, and when they touch the choriocapillaris, a double layer sign formed. That is a lateral growth of blood vessels in the potential space of the sub-RP space. Why is this extremely important? This is probably the first flag you can get of a CNVM happening, and that is the significance of the study. Subsequently, MNVs happen, and they were always associated with intense atrophy and pigment clumps, 100% association. So the theory of this aura, it's an OCT find. It's either because the retinal layers go down, or it is because of some new vascular changes that happen. And how do you differentiate it? This is a pictorial representation. You have hyperreflective changes, and as these changes collapses, you see the retinal layers going down. This is what we know. But you can transpose it on the vascular. You have the superficial vascular plexus and the deep vascular plexus. And you see the changes. This is the retinochoroidal anastomosis happening. But along with that happening, you see the layers going down because of subsidence, of atrophy. And finally, the deep vascular plexus is in the avascular radius. This is called vascular invasion. It's not supposed to be there. And when it touches the choriocapillaris, you have a double layer sign. This is probably the pre-proliferative stage of CNVM. Everything in blue is a non-proliferative, before a CNVM happens. The red is when a CNVM happens. So there's a very small window of opportunity for us. And that is demonstrated by this identification of the double layer sign, along with identification on the OCT of a blood vessel traveling through the course of the whole retina. So why is this important? Mactal is a degenerative disease. It produces a secondary vascular change. The vessels grow through all the layers. The vessels hit the choriocapillaris. You get a CNVM, but you have a small window by which you have a double layer sign, and you can potentially identify pre-proliferative MacTel, and all the key changes that can really damage your thing. So a vital pre-proliferative flag. That is what this study is about. The DLS in MacTel in the presence of this OCT finding called aura. There is no rationale to treat it at this stage, but you have a great way of saving severe visual loss due to an SRNV formation. Thank you.
So do you have any experience of treating such patients when you saw the double layer sign and you treated them?
No, this is very new, madam. This is the double layer sign is, even when you find the double layer sign in a non-exudative, you are not allowed to treat it. But the main point is that 5 to 18% of these people will convert to a full-blown CNVM in 1 year. So you have the you have the opportunity to tell the patients that they have to have a regular follow-up, even once every 3 months, follow up with OCTA to make sure it doesn't progress.
My question was, these were your patients.
Yes, ma'am.
And you diagnosed them to be having SRNV. Did you treat them?
With the SRNVN patients, we treated.
And how much improvement could they have? Because they were already a MacTel and there already a degeneration taken place. So how much did they improve?
So they would improve, but the final improvement would all depend on the ellipsoid zone loss. How much?
So in your study, how much did they improve? How much could you get the vision back? That's just my question.
The treatment is not a part of the study, madam. We didn't.
But I'm asking you.
No, if you're asking me, generally they improve well. They improve. It depends on how early you catch the CNVM.